It is a huge honor for me to be with my buddy Alan Honigman.
That's my honor, Howard.
No, it's all mine.
Well, it's all mine.
We both live in Phoenix, well, the Valley, and
Right.
I've been referring him perio for damn near 30 years, and he's a legend in so many ways. No, you really are. I mean, every dentist I know that knows you thinks the world of you.
Well, that's nice to know.
You're known as a great periodontist. You're known as an expert in lasers.
Yeah, I would say that.
Yeah,
Lasers
you
for
were
perio.
periodont. You know, when Millennium was associated with LANAP.
That's right.
And when they started coming out, they were with general dentists first, but now periodontists are getting
That's
involved.
exactly it.
So, do you call yourself a periodontist?
Absolutely.
But because I heard that the last periodontal meeting they had a vote to change the name to periodontal and implantology.
That's right, exactly.
And periodontist won by like 2%.
Actually, it didn't pass by one vote.
So what?
It didn't pass by one vote to change the name of the American Academy of Periodontology to the American Academy of Periodontology and Implantology. It didn't pass just by one vote.
So one more vote, it would have passed.
That's right. One more vote.
So do you call yourself a periodontist or a periodontist implantologist?
No, I'm a. You know, there's technically everybody who does implants can call themselves an implantologist. There really is no.
Say that again. Everybody
who does implants could call themselves an implantologist, because there really is no formalized training, like a specialty that says, "Oh, you're an implantologist." Like there's no ADA specialty right now that says just for implants. So you can't go like out of dental school and get your certificate in implantology. There's no technical specialty. So, but there's a lot of guys who are out there who do a lot of implants, and a lot of them do it well. And they take courses, the CE courses and things like that, or they go through the American Academy of Implant Dentistry. There's the MISH course and things like that. And that where you can get yourself really trained well to do implants well. But periodontists, we're trained in our residency mostly now, well, before, to do implants. And now you see a lot more implants being done even at the dental school level now. Not just restorative, but actually placing of the implants. So I guess everybody can call themselves an implantologist, but I'm a recognized board-certified periodontist. And
are you placing implants?
Absolutely.
So, but I'll tell you this.
I got to tell you one story though.
Okay.
I remember you called me up one day at my office, and you said to me, I can't remember, I don't remember what year, but it was like 2000 and who knows what. And you said to me, Alan, you ever had a problem going into the nerve? You asked me that. You ever had a problem placing the implant in the nerve and person gets paresthesia? I said, Howard, never happened. And you said, no, come on, just tell me. I said, never happened, because at the time I was one of the first users of guided implant surgery using CT scans. So I avoided that problem from day one when I started doing a lot more implants. And so I started now the majority of my patients get CT scans. I still do a lot of guided surgery. And so I avoid that problem. And knock wood, to this day, I've never had a patient have a paresthesia or hit a nerve or anything. So safety first.
I have my fellowship in the Mission Institute.
Right. Great institute.
My diplomat in the International Congress of Implantology.
Right.
I've never had a paresthesia from placing the implant.
Right.
But I have had 2 or 3 from giving an injection.
Oh, really?
And they all went away in about 6 months to a year.
That's great.
But I want to say this. We're about the same age, aren't we? How old are you? I'm 53. What are you?
I'm a little older.
Are you a little older?
56.
Well, you look younger than me.
Well,
it seems like of the 9 specialties,
right?
Endo, perio, pedo, all of them. Yours changed more in the last 30 years than all the other ones combined.
Oh, it's changed more, I think, personally, since I've been a periodontist. Since I graduated in '93 from UCLA, implants were just coming in to perio.
In what year?
I graduated in '93 from UCLA for perio. And we didn't have all the regenerative materials we have now. There was no such thing as resorbable membranes. There was no such thing as emdogain at the time. Bone graft.
Resorbable membranes, what was the other one?
Resorbable membranes, emdogain for biomimetics, for getting bone to regrow into defects. Gore-Tex membranes were just coming out. They were just starting to get more accepted into.
And wasn't that out of Flagstaff in our state?
That was, I think it was out of. Yes, Flagstaff. You're right. That's where Gore-Tex.
So you know how Gore-Tex started? It was all the telegraph wires, and
Yeah.
then they decided they wanted to put a coating on them.
Right.
So they built $100 million coating telephone wires.
Yeah.
And then up in Flagstaff, and up north of us in Phoenix, they started saying, well, that stuff would make great floss.
Right.
And then membranes and all that stuff.
That's right. And then it came out.
Yeah.
So sinus lifts, no one was doing any no periodontists definitely weren't doing any sinus lifts at the time. So I've seen a transition. So we were taught a lot of surgery, cut the gums away and let the restoring dentist worry about everything else. Our job was just to make sure everybody had no pockets. You couldn't even do immediate implants. Now it's like almost standard, like, oh, take a tooth out, place an implant. We didn't have that option because no one even thought about it. And all on fours it was a pipe dream. So no one even thought about what was going on. So over the last 25 years, 93, 23 years since I've been practicing perio, I have seen a lot of changes that's happened in perio now. Resorbable membranes, bone grafting, different bone grafting materials, biomedics, BMP, PRP. I mean, all these things have really changed how we do perio. I think that one of the biggest changes that I've seen over the course of my time now, because I've almost been doing this for 10 years now, I would say is LANAP. And that's really been a cornerstone now of my practice, of using the laser-assisted new attachment protocol from Millennium. It really changed the way I practice, and it changed the way I look at my patients, and it's changed the way I look at what we would have considered hopeless teeth before. So,
and by the way, Al and I both had laser hair removal.
That's right. It won't
with
grow
the
hair,
Millennium
unfortunately.
laser.
So
if you're tired of shaving your legs and your underarms,
we can help you with that.
So LANAP. So explain LANAP. Why do you like LANAP?
Why I like LANAP? Well, I was looking for when I got into the Valley when I opened my practice in 2003. And that's when I met you, 2003. I wish it was 30 years.
Because I was there in '87.
Yeah, no, I was.
I always thought you were from the original.
No, I was in San Antonio getting my dental school done in '87. So.
San Antonio.
Yep, San Antonio, Texas. So in 2000, I opened my practice, and by 2006, we have periodontists all over the Valley, and I was looking for a way to distinguish myself from the other ones because we all do grafts, we all do implants, we all do whatever it is, but I wanted to find a way to separate myself out from the pack. So I looked into this procedure. I got a call from an old student of mine because I was teaching a case for a couple of years. And he said, Alan, you got to get involved with this. It's amazing. And I said to him, you're crazy. I've done a lot more surgery than you have. He's only been on residency like 2 or 3 years. I said, I've done a lot more surgery than you have, and it'd be hard for me to understand how a laser can do what I can do. And he just kept harping on me for almost a year. And a big shout out to Suresh Goel. Thanks a lot, Suresh. And anyway, so he harped on me, and eventually I started looking into it, and I got on Dental Town.
What was his name? Suresh?
Suresh Goel. Goel.
Goel.
Yeah.
Suresh. And where's he out of?
He's out of Rochester, New York.
Okay.
And he does a lot of work now with Bruce Baird's group, the PDA.
Productive Dental Academy.
That's right. So he's doing a lot of work with them. So, but yeah, he was one of. It's hard to think about it, but like a student was a big influence on me. So I looked around and I contacted Bob Gregg through Dental Town. Bob Gregg called me back, and we talked about it. And I said, okay, let's do this thing. And
is his wife a dentist too?
Yeah, Dawn.
Is she a dentist?
Yeah, Dawn's a dentist also, and she
Greg and Dawn, and what is her last name?
Well, now it's Dawn Gregg.
So it's Dawn Gregg.
Dawn Gregg, yeah.
And what's Greg's first name?
Bob Gregg.
Bob Gregg.
Yeah.
Okay, so Bob Gregg and Dawn Gregg are the founders of LANAP or Millennium.
It was Bob Gregg and Del McCarthy developed. This was interesting about the procedure itself. Is Bob Gregg and Del McCarthy, they got tired of their patients going to the periodontist and either not getting work done or half the work done, and they said there's got to be a better way to do this. And they were big into lasers at the time, and so they started experimenting around, seeing what lasers did what, finding the right laser, finding the right wavelength and the right protocol. And so what they did was they figured all that out first, then they developed a laser to fit their protocol. Whereas a lot of laser companies will build a laser, then say, hey, what can we do with this thing? And then try to fit the protocol to fit the laser. So they developed this back in the 80s and 90s, and then they came out with LANAP. And it was hard pressed it was hard to sell a lot of periodontists on that a laser can do what you got all this training for and all your surgical skills. But yeah, so they started doing that, and then I know Dawn got on board in 2001, right after 9/11, actually. And what's interesting is Dawn was one of
Is she a general dentist or
general dentist?
And Bob Gregg,
they're both general dentists.
Okay.
So, and we're seeing a lot of perio innovations come out of general dentistry, which I think is fantastic. So Dawn got on board, and what's interesting is when I was a resident, Dawn was one of my students in dental school. She was a dental student, so I was one of her residents that we used to go around and check her perio. And so then when I came on board, she was one of my instructors. So things always come full circle sometimes. But so anyway, so I remember I was just looking for a way to just change my brand, I guess you could say, and increase my awareness of perio, because I got tired of cutting gums. I got tired of seeing patients come in for half their mouth and we cut their gums away and then suture everything back, and now they have a lot of sensitivity and they don't want to go back, and now your poor hygienists are stuck with these patients who have half mouth is okay, the other half is still got a lot of deep pockets, and you've got to find a way to fix these exposed roots. So I talked with Bob, and I called some other periodontists in the country and talked with them, and they said get on board with it, and so I did. I made the leap. In fact, my future ex-father-in-law at the time.
Your future ex-father-in-law.
I didn't know he was going to be my ex-father-in-law, but he became my future ex-father-in-law. He was a big-time periodontist, and he'd lectured a lot for Implant on guided surgery. He's the one who got me into guided surgery. But he told me I was crazy. He said laser can't do what we've been trained to do. And when I told him what I was going to pay for, he says, "Oh my God, I'm having a heart attack." And I said, "I'm still going to go with this because they said we have a clinical money-back guarantee. If it doesn't work, we'll take your money back." And Bob says, "Alan, I'll take the laser back. I'll give you your money back, and we'll part friends." I said, "Great. I can't lose. If it works, I got a great thing. If it doesn't work, I'm going to get my money back. I can keep doing what I'm already trained to do." So I ended up making the leap, and I remember going back after at the 6-month mark when you can make your decision whether to give the laser back or what. And Bob asked me. He says, "Hey, Alan, are you going to give the laser back?" And I said, "Bob, you're going to have to pry from my cold, dead hands," because I saw an increase of patient acceptance, because there's a fear factor involved when it comes to perio. If you send your patient to the periodontist, there are only two things they think about: how much it's going to cost and how much it's going to hurt. And so if you can take away the technically surgical aspect, when they realize there's no real cutting or suturing, there's no scalpels or suturing, all of a sudden that fear is gone, and then finding the way to pay for it all of a sudden becomes a lot easier for them. So it changed the way I practice, and I know it's changed the way that a lot of guys have practiced in the Valley, because I was the first periodontist in all of Maricopa County to have it, and then all the guys who poo-pooed me, they jumped on board about 4 or 5 years after me. So there you go.
So is it getting more accepted by periodontists nationwide?
It is now, actually.
Like how many? There's what? How many periodontists you say there are? 4,000?
Maybe just in the Valley. Sometimes it feels that way. No, I think there's 8,000 periodontists all around. But
in the whole world?
Maybe in the whole world, yeah.
And
but,
half of them are in America?
Probably in America, yeah. But about 35% of active AAP members are now doing LANAP. Which
35%,
is over 35%
of active American Academy of Periodontics.
That's right, are doing LANAP. And so that's just...
So then
why isn't everybody?
Well, no. I mean, I think that means it's valid.
I mean, absolutely, it is valid. And if you look at a lot of things that we do in dentistry, a lot of it is peer-to-peer. Like, if you come up to me and say, "Hey, Alan, I'm using this new product, and it's really good. It's been great results in my hands. I may not know anything about it, but I'm going to look into it. I'm going to try, because you're someone I trust. You have no reason to see me fail. So why wouldn't I trust you?" So therefore, peer-to-peer is a big thing in all of dentistry. That is what we do. So I mean, CEREC is a big thing. I mean, look how that's just blown up.
And they don't have 35% of dentists. I mean, they
have a lot of dentists who do it.
They probably don't even have 15% of dentists.
We don't have 35% of all dentists. We have 35% of active AAP members. But there's probably over 2,000 dental professionals in the U.S. who do it, and now it's worldwide. Now we have doctors in Italy, England, the Philippines. We have 4, 5, or 6 in Australia alone. Canada.
So it's 2,000 dentists are doing LANAP in America?
Yeah. General dentists, periodontists. We have oral surgeons doing it. We have, I think there's actually one.
Yeah,
endo.
I think one of the things that's the barrier to start this is this ain't cheap.
No.
I mean, how much does it cost to buy the Millennium Dental Laser and go through the training to start doing LANAP?
Well,
isn't it like $130?
It's less than $130 actually.
How much is it?
Right now, I know it's over probably like 108. but I don't know exactly what the cost is. They don't. That's above my package.
So $108,000. You guys saying, dude, Alan, I could buy a house. I could buy a house.
That's right. Exactly.
A rental property for $108,000.
Right.
So tell them why they should spend $108,000 buying a millennial laser and learning LANAP.
Well, because if you look at it, if you went to buy a house, and they said it's $300,000, you can't plunk down $300,000 tomorrow. No one's going to.
You get a mortgage.
You get a mortgage, right? So what do? You get it. You get yourself a lease, and you lease it out over 5 years, 7 years, whatever you feel comfortable doing, and then all of a sudden it becomes much more manageable for you.
So what's a 5-year lease on $113,000?
I don't know, $1,800, let's say. I don't know.
$1,800
a month.
Okay.
Okay. So
now we're talking about, instead of a $113,000 number on a balance sheet,
right,
where your assets equal your liabilities plus equity, you're talking about, let's look at this on a statement of cash flow.
Right.
So you're paying $1,800. So if I'm paying $1,800 a month towards this,
right,
how do I increase my cash flow $1,800 a month to pay for that payment?
That's a good question. And this is what I tell a lot of general dentists, is that what you would do is, if you have, a lot of dentists will see pockets, 6, 7, 8 millimeter pockets, and they'll go through scale and root planing, and then they'll come back, and then you'll say, well, you need to see the periodontist, and then go send the patient to the periodontist. So instead of taking them through scaling and root planing, which is really not a definitive treatment, you would take them through LANAP instead. So you take them to a higher end procedure, but it's a more definitive procedure.
So would you do the cleaning first?
No, actually, the interesting thing with this particular wavelength, the grungier and uglier and more inflamed the tissue is, the better the procedure works.
Okay, so let's walk through this. So a new patient comes in.
Right.
They need 4 quadrants root planing curettage.
Right.
Take it from there.
Take it from there. I would look at the pockets. If they're like, 4s and 5s and almost no bone loss, I probably do scaling and root planing and let them heal and evaluate them later. If I start seeing, if my hygienist takes the x-rays and I start seeing vertical defects, furcation involvements, 6, 7, 8, 9 millimeter pockets, I'm going to stop them there. I'm going to say, look, your disease is getting a little bit more severe than the average person. And we have videos. We have a lot of good marketing, actually, which I use a lot of. And show them a video, describes the procedure, describes the 3 procedures: scale and root planing, traditional osseous surgery, and LANAP. And then that's it. I show them this video, and then I talk to the patient. And if I show them the video, I know they're going to be a good candidate for LANAP. And probably about 9 times out of 10, they're going to take the LANAP treatment, because it tells them that they have a severe enough disease they need more than just a deep cleaning. And we have a way to fix them without cutting and without sewing, and that's the key. If you take out that scalpel suture, all of a sudden, it's like, that's not bad.
Would the dentist be doing? Would the hygienist be doing?
No,
the 4
this is a dentist thing. So actually,
now you're moving 4 quads of root planing curettage out from hygiene into the dental.
Right, but you're getting. It takes. If you charge out.
What would 4 quads of root planing curettage be?
It depends on if you're PPOs or anything else.
Yeah.
4 quads.
The average PPO price in the Phoenix Valley.
Probably about $800 a quad.
So 4 quads of root planing curettage.
No, 4 quads. That'd be 4 quads of osseous surgery. That's about 4 quads of osseous surgery. If you look at
$800
about
for
$800
4
a quads, yeah. No, $800 per quad.
So that'd be $800, $1,600, $3,200.
Right. So if you transition just 1 patient a month, okay,
you double your money.
And that's just 1 patient a month. So 12 patients a year, you'll make all your payments, plus you'll have money in your pocket. So if you do about 60, 70 patients, you've already paid for it. So if you look at it from a general dental standpoint, general dentist standpoint, what you're getting is you're tapping into a revenue stream that you had no tap into before. Now, am I saying you're going to not refer any more patients?
When you do LANAP, you can bill out. What code is it?
There's different codes you can bill out at, depending on severity. Some doctors will bill out 4260, which is osseous surgery, 4261, which is osseous surgery for 1 to 3 teeth. You can do 4240, which is gingival flap for scaling and root planing, and 4241, which is gingival flap for scaling and root planing for 1 to 3 teeth.
And these are generally $800 a quad on a PPO price?
About, depending on, now the 4240 is going to be a little less, but they're more than doing scale and root planing. So that patient that, let's say, had 4 or 5 millimeter pockets with a lot of bleeding and a lot of inflammation, I may recommend LANAP, but charge out the 4240, which is gingival flap for scale and root planing, which is basically what I'm doing.
And what % of these are getting paid by PPOs?
They all get paid by the PPOs. I haven't had any problems in almost 10 years.
Do you think it's because only 2,000 dentists are doing it, but
I think
if 20,000 dentists are doing it, they crack down?
No, I think it's just because if the probing depths and the X-rays match your code, they have the insurance companies really have no arguments against it.
So the insurance don't know if the probing depths are real. You could make that up. But,
well, we wouldn't do that.
I know, but you got to think of worst case scenario. So do you think it's the radiographic evidence that the insurance?
I think it's the radiographic evidence mostly,
and
because you'll see bone loss.
And what would they be looking for?
They're looking for bone loss. They're like more than just a hair. They want to see bone loss below the CEJ. And they want to see some, maybe a vertical defect or something, but significant amount of bone loss. Not like, I'm not talking like 80%. If they see like 10% bone loss, yeah, the pockets are probably 6s and 7s and things like that. Now, back to the cost. What's interesting is Millennium just rolled out, actually just started at this meeting, is they're running, because you were saying that's a big nut, 108, right? Or whatever they're charging now, who knows, to get a discount, I don't know. But if you, what they're running out now, because they want to see more general dentists, they want to see more people get involved in this, because it really is great for the patients, is what they're running now is a leasing program for it's about 40% off. You lease it for 3 years. That includes all the training, 5 days of training. That's over the course of a year. And then at the end of 3 years, you have the option to give it back, just like you would a leased car, or say, you know what, I want to pay the difference. That's been locked in before, and you can pay it off.
So why don't you make an online CE course on this?
We actually have them.
On Dentaltown?
Not on Yes, I did a CE course on LANAP and LAPIP on Dentaltown last January.
It was last January?
Yeah.
Huh. And is that right?
Yeah, I came down to the studios
with Howard Goldstein?
Not with Howard, with Wendy Allen, who used to be the marketing person for Millennium. We came down, I talked to you, and then we did it in front of the big screen.
Huh. I thought we filmed a Townie Live lecture.
I did a Townie Live lecture 2 years ago.
Yeah.
Maybe you did that too.
Okay.
I didn't see that one.
I was thinking
anyway,
that.
But there is a way now for people who may not like that six-figure number to get into it and see the benefit that they're going to get, not only to their patients, but to the bottom line. And that's once you start seeing the amount of work. Like I said, if you just convert one scale and root planing patient a month, just one, you're gonna make your payment for your lease, and you're going to pocket money too. And how do you get out of that?
Okay, but are you talking about when you talk about LANAP, are you talking about periodontology on natural teeth, or does this play into the booming peri-implantitis?
Absolutely. That's actually where this is really starting to pick up now, especially with the periodontists and the oral surgeons. Like I said, we've had oral surgeons buy this thing, not for perio, but just to treat peri-implantitis. And I've been doing this for about 4 or 5 years now for treating peri-implantitis, been getting great results. Because again, if you look at the treatments out there now, all involve surgery, flapping it back, putting in membranes, putting in bone grafts. And those all cost money, and patients will balk at a certain price point. And they may say, you know what, take the thing out and just put a new one in or whatever. This actually is a wonderful first option treatment for peri-implantitis, because one, we're getting rid of the bacteria, we're removing diseased tissue, we're disinfecting the implant, even though we're not using the laser directly on the implant. It's just through scatter of the laser radiation that we're getting, and then we clean everything up, and that's it. And we use the laser again to seal it off, and we're finished. It takes me less than an hour to do 1 or 2 implants. No traumas, very little to no trauma to the patients. They follow the instructions. Then it's just all follow-ups, and then we just watch the bone heal. And it's really amazing the results we're getting. And the nice thing is, because we haven't cut tissue, we haven't removed tissue, we haven't put in a bunch of junk in there, if we have to and we still don't see the results we want, or we get a little inflammation, we can still go back in and retreat it.
Okay, but then after you did that on peri-implantitis,
yeah,
would you put that patient on 3-month recall and keep doing it, LANAP again and again? What would you do?
What we do is, first of all, you have to think of people lost teeth for a reason. Usually if people have lost a lot of teeth and they have a lot of implants, it's usually due to periodontal disease. These patients are at high risk of losing, having problems with their implants. So what you want to do is you want to keep that, especially the periodont, you want to keep their periodontal status around the natural teeth as healthy as possible. So I've always felt that patients who have implants should be coming in every 3 to 4 months for perio maintenance, and at least once or twice a year having a periapical X-ray taken of that implant, so you can follow to see if there's any bone loss all of a sudden, and so you can catch it before it becomes a bigger problem for them.
Once a year.
At least once a year, they should have a periapical X-ray taken. twice a year. I would love to see, once every 6 months if they're coming in every 3 months, just to make sure that, because I've had cases, and a lot of periodontists probably had cases where the patient comes in and and all we have is a bite wing, and the bone may look great at the top, and then what you do is you take the PA and there's this big radiolucent area at the apex that may have been caught a lot earlier.
So, Alan, when you look at most marketing and advertising on implant companies, they're all saying their implant has about a 4% failure rate.
Yeah.
There's a lot of people that are more cynical bastards like me who think that the American national average implant failure rate may be as high as 20%.
Actually, it's if you look at peri-implantitis studies, they can go as high as 40%. You have to understand, when someone says they have a 4% failure rate, and they say we have a 96% success rate, what that actually means is they're not looking at the levels of the bone. They're just looking, was the implant in or not in? The bone levels really aren't taken into account. So you have to look at it from that standpoint. You have to understand that's what, when you see those success rates, that's what I'm not looking at those. I'm looking at how much bone is lost over the course of the years. Now, is there one implant better than the other? I don't know. I've used 5 or 6, 7 different types of systems. I found they all work well, but as long as you stick to biology, as long as you don't try to, stick them into really thin bone, or, try to push the envelope too far, or if you don't understand exactly what you're doing. That's why, I think people who go to the MISH course are far ahead of the curve than those who go for the weekend warrior courses sometimes, because placing implants are easy. It's when you get into complications, that's where it becomes hard. And if you don't know how to handle the complications, you really shouldn't be placing the implants at that point. So
my homies out there, they see implants that are up to $500 for a Noble Biocare, down to $125 for an Implants Direct,
right.
And there's some coming out of Israel and Russia that are under $100. Is how does an osteocyte know if you're Noble Biocare or Megagen or Implants Direct? Where can you save money and where are you being foolish?
I think that when you're starting out with implants, I think you have to go with one of the bigger companies, Nobel, Straumann, those ones. And I'll tell you why, because they have a much better, I think they have a better customer support system. The reps are going to come out, they're going to help you out, they're going to help you order the implant, order the parts and everything else. But Straumann, but the mid-rank Megagen, didn't Straumann give Megagen a $30 million convertible bond? That I don't know.
Yeah.
And
they got to sign by June. So it could be by June 1 if Megagen signs that.
Yeah.
Then the medium cost Megagen would be actually a Straumann.
That's right. So I always suggest start off with some of the bigger, more studied implants, because there's more data behind them.
Name names. Which ones?
Like Nobel, 3i, Straumann. I've used Astra. I think makes a really nice implant.
Astra was Dentsply?
Astra is now it's Dentsply now. So there's another one, I can't remember the name of it, but there's a lot of great implants out there. But as you get better and better at doing them, you start realizing that as long as you stay within the biological parameters of a millimeter bone around the implants, proper distance, proper occlusion.
Just 1 millimeter all the way around?
You need at least 1.5 millimeters around an implant.
A millimeter, 1.5 millimeters?
I always go with 1 millimeter, but
if you have 1 millimeter all the way around, do you think you're good?
I think you're pretty good at that point, as long as you have at least 1 millimeter of solid bone around there. It can't be thin, like you can't look through and go, oh, there's the implant. Like good solid, and I always like to place things subcrestal. I don't like right at the crest. But the point is that as long as you stay within biological parameters, your implants are going to work. And as you get better and better, then you can start looking at some of the implants that cost a little less. Implant Direct, I think, makes a good implant.
And who's the founder of that implant?
Implant was
Jerry Resnick.
That's right.
Was it Jerry Resnick?
Not Resnick. It's
Jerry.
Oh, I can't think of his name now. I know him too. I've met him several times. I can't.
What the hell's his name?
I don't know.
Was it Resnick? Jerry?
It's not. I think it's Resnick though. Isn't that crazy?
One of the smartest guys in all of dentistry.
It'd be brilliant the way he did it.
Oh my God! Because he started Corvent.
They started Corvent. Then he developed the. Then he developed the internal hex, and he patented that, so everyone had to pay him. And when the patent expired, what happened? I think he bought out by Zimmer. Zimmer bought out Corvent. He developed the internal hex. then that was patented. So any company that used internal hex had to pay him a royalty, and he couldn't start making implants until I guess some deal he made with Zimmer ran out. Then he was already tooling up for the implant.
Right. And then he sold that to Kerr, which is owned by Cybern, which is owned by Danaher.
That's right. Danaher, I think, knows everybody.
But the rumor is that his 5-year restricted covenant has ended.
Oh, really? Oh,
and
who knows what
he's
who
back.
Knows That's right.
He's back. And I called him. I said, rumor has it you're back. I said, I want to do a podcast on it. He goes, well, I'm not back yet, but as soon as I'm back, I'll podcast you.
So there's Implant Direct makes a lot of, I think makes a good solid implant. And they include a lot of things. They include they include a healing cap, cover screw. They include an abutment if you want to use it, or you want to use it as for an impression coping. I mean, that includes a lot. MIS, I've been using MIS for a long time. MIS. They're out of Israel. Wonderful implant. Again, they include the cover screw, but they also include your final drill. So your final drill is always a sharp drill, which is nice too. So you can almost use any system you want to do your initial osteotomies, and then use their final drill, get the final shape, and then place your implant.
You know how I got Ryan's my podcast, my son.
Yeah.
You know how your grandma, my mother, Colleen. You know why I am her favorite son?
Why is that?
Because I sent her and her 3 girlfriends to Israel on one of them bus tour things.
Oh, yeah.
She still thinks that was the highlight of her whole life. She spent 20 days seeing where baby Jesus was born, and they're just oh my God.
That's amazing. So there's a lot of implant systems out there. I think Hyosin has a good implant system. Dentium has
Hyosin, that's Korean.
That's Korean. Hyosin has a good one. Dentium has a good one.
So what's the other? Order all the Koreans. Hyosin, Megagen. There's a third one in there.
Dentium,
is that Korean too?
That's Korean too, I believe. And everybody has just like anything we do, there's no one implant to fit every single category. So, sometimes you use a different implant system for a different case. So, like Astra has a slanted implant on the top. It's angled so that for the ridges that have, high in the lingual but low on the buccal. So it fits right in there, so you don't have to worry about having one part right.
Okay, I'm gonna start just bulletproofing. Yeah, the most talked about threads on Dental Town about implants.
Yeah,
screw or cement.
I like the screw retain for the posterior. If you can do a screw retain in the anterior, that's great. But I think the anterior is easy to get the cement off of. But I like screw retain more for posterior teeth because of all the peri-implantitis I'm seeing that is basically. A lot of it is because of what I call cementomas. Cement underneath the bone, underneath the
But what if you just change your cement? Because some people are saying that, well, if you just didn't use a resin cement, but you use, like, say, zinc phosphate cement.
No, that's anything that's going to... The whole idea behind the peri-implantitis is that it's still caused by bacteria that's from periodontal disease. So what you have to realize is if you have anything in there that's going to disrupt that... tissue interface where it's kind of like tight against the implant, bacteria is just going to get in and things are just going to start blowing up because there is no periodontal ligament to kind of slow the progress. There is no connective tissue attachment. It goes right from top all the way down to the bone. It's like an osteomyelitis. It infects the bone right away. There's not like a progression until it reaches the bone. So you have to be careful with that.
So how much of peri-implantitis is treatment planning? I'll see new patients and they got peri-implantitis where someone sunk 2 implants in a mouth for a bridge, and they had 6mm pockets on 5 other teeth. I mean, is a lot of peri-implantitis from diagnosing and treatment plan errors?
I think it's more of that you have to look at your cases from the standpoint of if you have a patient who comes in who's got periodontitis and like inflammation and everything, you have to take care of that first before you place your implants because you have to remember that bacteria, the periodontal bacteria, don't have zip codes. They don't just stay in their own little spot. They're jumping around. You're brushing your teeth and moving it all around too. So you have to have a clean mouth really to get an implant in. So, and actually that's the nice thing about LANAP is I've done implants at the same time I've done LANAP because I'm cleaning everything off. I'm getting rid of the bacteria. It's the cleanest the mouth is going to be in a long time, and I can place that implant right away.
So that leads me to this theoretical question, because I don't think anybody really knows the answer, but I want to see what your opinion is.
Okay.
So let's say we got 2 patients, and one person has lost 80% of their teeth from root canals, and the dentist tries to clean it up, and they try to save some canines or whatever. And the other person just eradicates the whole disease, pulls all the teeth, puts them in a denture for 3 months, where there would be no anaerobic environment for the P. gingivalis to live, and then goes back and does like 4 on the floor. Do you think there would be less peri-implantitis if there was no teeth that could have any bleeding gums, and you went to a full extraction? Because I don't care if you have full mouth gum disease, you pull all the teeth and make them a denture, you take those dentures, their gums are all pink. But there's no gum disease.
Well,
so did you? So,
there's no teeth.
So when you pull all those teeth, did you eradicate P. gingivalis because there's no gram-negative anaerobic environment for them to live in?
No, actually, they're still within the tissues
of the tongue and the tonsils.
No, under the gum, they're still in there.
They're still in there.
They're still in there. They're just waiting because they're intracellular, so they can live within your gums. So when you start, now you're putting kind of teeth back in, you're disrupting that sealed environment now with an implant that's popping up through the gingiva. So now it's like, oh, great, thanks a lot. Now I can start. Is that right? Again.
So you pull all their teeth and they have a denture and they still have P. gingivalis in their gums.
Yep, and that's the key to doing LANAP is we're eliminating. That's why LANAP is like a full mouth protocol. People will go, well, you know, he's just got a couple of 6s in the back. Why are you doing the full mouth? Because the P. gingivalis is everywhere. It's kind of like bringing a exterminator into your house. If you tell the exterminator, look, just work in the kitchen. That's the only place I saw the bugs. He's going, no. Your bugs are everywhere. I'm going to treat your whole house because if I just treat here, they're going to show up somewhere else. They're just going to move somewhere else. So that's the idea behind LANAP. It's a full mouth protocol because we want to, even though the anteriors may be only 3 millimeters deep, we want to make sure we're trying to do the best we can to make sure that P. gingivalis is gone.
Okay, so now what are you going to say to this? There's some people in dental town that say, okay, I get it, the laser is great.
Yeah.
But the laser's a laser. Why not just buy the $2,500 AMD laser? And why do I got to buy the most expensive Millennium laser?
Right.
Isn't a laser a laser?
No, it's not. A laser's not. That's the one thing I say in my lectures. If they take away anything from the lecture, a laser's not a laser, not a laser. Lasers, you have to look at where it's absorbed. So like the erbium is absorbed in highly absorbent hydroxyapatite and in water. Well, that's where it works. It works by blowing up water within the cells, in the tissues and everything else.
That's erbium.
That's the erbiums. So if I want to
what's millennial LANAP?
Millenniums is an ND-YAG. ND-YAGs are not well absorbed in bone at all. They're not absorbed in water at all. So you can fire a laser, an ND-YAG, through water and nothing will happen. We have what we call the carpule trick, where we'll just remove the black lettering from the carpule, but the water won't heat up because the water doesn't absorb it. So that's why it works. Because it's not very well absorbed in bone. It's not absorbed in water at all, but it is well absorbed in dark pigment, in melanin. So like dark pigment bacteria, dark, very infected tissue. It's really well absorbed there. And it's also moderately absorbed in hemoglobin, which allows us to develop blood clots, develop a fibrin clot to seal everything off at the end of the procedure, to act like the patient's own guided bone regeneration, or its own Gore-Tex membrane technically. And so we don't take patients off blood thinners. So it's been wonderful for me for that stuff. I mean, it's no sense having a stroke just to save a tooth. Or take out a tooth. Where a laser is absorbed determines what it can do. So a laser, not a laser, not a laser. Now, the AMD, or let's say the 2500 diode, it's a great laser for what it can do. Problem is, it has no penetration qualities to it. It just kind of cuts whatever's in front of it. It's just a hot tip. It's basically, I like to call the diodes electrosurge with light. It's just going to cut whatever's in front of it, has no specificity, where the ND-YAG from Millennium, because we can tune it, we can selectively remove just diseased tissue and leave behind the healthy connective tissue. And that's the key. And kill the bacteria, not only at the point of contact, but 2 to 3 to 4 millimeters past the point. That's where the energy is going. Where a diode will only kill bacteria at the tip.
What else for peri-implantitis? I see so many threads about peri-implantitis. Yep. Some people are sticking these tetracycline chips down there. Some swear by Paradex because chlorhexidine glucanate's an oily, kind of sticks to the implant. Some people are just putting them on tetracycline, Keflex. Is that all voodoo, or do you see any therapeutics in it?
You know, even when I do LAPIP, which is for the peri-implantitis, I will.
Okay, explain that. You said you went from LANAP to LAPIP.
LANAP is laser-assisted new attachment protocol. That's for perio. LAPIP is laser attachment peri-implantitis procedure for peri-implantitis. But it's basically the same procedure, except we're just doing around implants. So That's the nice thing about it. We're not really changing much except watching the amount of energy we're putting in so we don't overheat the implant. And that's really nice too. So, what was the question?
well, is there any of these other adjuncts? Some people are saying, switch with Paradox Twist A. Some are putting them on tetracycline because they say that tetracycline shows up in crevicular fluid more than say amoxicillin.
The problem is you're not going to get the bacteria kill that you can with a laser treatment. You're definitely not going to get it with the Nd:YAG because of the penetration qualities, because it's selective.
So this is something to do. Okay, here's where I'm at. I know what the endodontists say, but I know what my homies think. You're talking to 1,000 people there that every time 1,000 that just after 100% of all their root canals give them penicillin.
Right.
When the endodontists say no. Right. You're talking to thousands of dentists there that after every root canal, give them a script of PenVK. After any time they see peri-implantitis, they give them tetracycline or PenVK or amoxicillin. What would you say specifically to your homies that when they see peri-implantitis or they see someone on a 3-month recall and they got bleeding 6 or 7, say, here, you need a script. You need some PenVK, amoxicillin, tetracycline. The
problem is with giving those without doing anything else is that it'll give you just a transient kind of result. It's kind of like a patient who comes in and they have a swelling, give them, and they need a tooth out or they need a root canal, and the swelling goes down, and they go, oh, I must be better now. And then what happens is 3 months later, it blows up again on them. It's a transient result. You have to hit them with different things. Now in perio, there's some cocktails of amoxicillin and metronidazole, or clindamycin and metronidazole if they're allergic. So there's different cocktails we can give them, but you still have to get to the heart of the problem, and that's getting rid of the calculus and getting rid of the bacteria that's actually within it. The problem is that to get rid of the bacteria within the tissues, the amount of antibiotic you would have to give would kill a patient. If you think about it, we only have a certain level we can get. But the nice thing about using the periolays is that we can kill the bacteria directly where it is, because as far as I know, bacteria have not developed resistance to laser energy, and they never will. So by using that in conjunction, like even after LANAP or even after LAPIP, I will always give a patient an antimicrobial. Give a patient and I'll have them swish with Paradox too. Paradox, you have to understand, only really works on the outside of the gums. It really can't penetrate deep under the gums in this 5-6 centimeter pocket. You can't really inject it in there too. It's going to get flushed out by the gingival auricular fluid. So you have to get something down in there. Also, to my homies out there who are looking at peri-implantitis, look at the cause of the peri-implantitis. Look what's causing it. A significant number are going to be because there's cement around that implant abutment interface. And look at the occlusion also. You got to have, on implants, that you want to have light to almost no occlusion. Implants are to be seen but never heard.
What about that company out of St. Louis that's making the trays? What is it called? Periodontic?
Perioprotect.
Is that out of St. Louis?
I don't know where it's out of. I know the product though.
Yeah. What do you think of that?
I think just like anything else, it has its uses. Would I use it on a patient who came in to see me and they have inflammation and calculus and everything? Probably not. I would probably wait a while to use them and make sure everything was cleaned up first. Then maybe use it as a something to kind of help them along. I know some periodontists I've talked to, they've used it for their refractory patients who just, no matter what they do, they're clean, everything else, they're still breaking down. You're just trying to get something else in there to help them out. But for the average patient, personally, I don't use it.
So, Alan, a lot of these, most podcasters are young. They're almost all under 30.
Yeah.
So a lot of, I'd say probably 20% are junior, seniors in dental school.
Yeah.
And 80% are probably been out 5 years or less. So they don't see what I'm going to say because I've been doing this 30 years. But why is periodontology seem to just be flatline for 8 or 9 years and boom, it's all flames up, and then it's flat for a while, then boom, it's all, you know what I'm saying?
Yeah.
It's not like a linear disease where every year you get more deal. It seems to be flat, boom, flat, boom. Why is it like that?
Because you're talking about it's a multifactorial disease. So it's not just like kill the bacteria, get rid of the disease. If we could do that, the periodontal disease, give the patient some antibiotics, okay, you're cured, see you later, goodbye, we're done. It's so multifactorial because a lot of things affect it. So it's very cyclical. So it has times of quiescence where there's nothing really going on, and your hygienist going along, oh, everything looks good, Mrs. Smith, and all of a sudden, 2 years later, all of a sudden, all these pockets show up. You go, what happened here? I don't know. So also, patients don't follow through on their perio maintenance a lot. So they'll be like real gung-ho maybe the first year, then all of a sudden they'll kind of drop off. Oh, I moved, I did this, I had a death in the family. Things happen in life. And usually cleanings get pushed off to the side. So what happens is they're not brushing 100%, no one brushes 100%, but they're not getting to everywhere they need to be. Bacteria starts repopulating and things start breaking down again. So that's where we get that kind of cyclical. It'll just kind of come up, it'll be steady like you said, and then all of a sudden they'll have this big spike, and then it'll maybe then they go, oh, it's starting to hurt, so they get themselves cleaned, and then it goes down, then it pops up again. So it's so multifactorial. Patients who are pregnant, they got all these raging hormones, and the bacteria love those cholesterol steroids, so they're going to eat those up. So they're going to have all this food source, and all of a sudden that's where we get the pregnancy gingivitis from, and major amount of inflammation going on there. So it's real important if patients are pregnant to make sure they're getting their teeth cleaned either before they get pregnant, if they know they're trying to plan, or at least at the 3-month mark, and then maybe at the 6-month or the 4-month, then the 6th or 7th month, and then try to keep everything under control, because we see a lot of pregnancy gingivitis come up.
I had a patient once, just not very long ago, and I'd seen him every 6 months forever.
Yeah.
And then it was time for his new FMX, and we took this FMX, and he had 3 different root canals and 3 different quadrants that all of a sudden were failing.
Yeah.
With a periapical. And I looked at the root canals, and I thought, well, how would those 3 root canals and 3 different quadrants all of a sudden be failing? And I said, you know what? I think some systemic's going on.
Yeah.
So I sent him to the physician. I said, I think something's wrong in your underlying immunity.
Right.
And it turned out a week later, he called me up and he says, yeah, dude, I got full blown cancer. So he lost his whole immune system.
Wow.
And that's why he threw. So gum disease is multifactorial.
Oh yeah, it is. You have patients who smoke, patients who are diabetic.
Okay, well, you just walked into a trap there. Okay. So here's another thing that these guys will debate about till 3 o'clock in the morning. It seems like, how many dental implants do you have in your mouth?
None.
Okay, I have none.
Yeah.
So the people losing their teeth and needing implants, usually they had some behavioral things. There's some there's
a reason behind it.
We didn't do anything wrong to lose our hair.
That's right.
But they usually did something not quite right to lose their teeth and need implants.
Unless they broke their teeth off or something else.
So there's all these purists says, I won't do implants on a smoker. I just want, it's a red line. Then other people saying, dude, well, that's half the implant market. There's reasons why people, Carl Misch and his brother Craig is the class example. Carl says, well, that's why they lost tooth. Of course, I'm going to put implants on smokers.
Right.
And his brother Craig's a purist, says, no, if you still smoke, you don't get it. I'm not doing it, so you quit smoking. Do you place implants in smokers?
Absolutely. I do. I think you can't let those people walk out because someone else is going to do it, if you think about it. But I look at it from the standpoint that I inform them up front, look, you smoke. The success rate for smokers is about 85% for implants. Now, like we talked about before, what that means is 85% of the time after 5 years, those implants will still be in the mouth.
After 5 years.
After 5 years, they'll still be in the mouth. So,
it's damn good.
And you can't let patients, if
my wig fell off after a week. And I can't even find it.
I try to get implants to get something stuck to my head, but they wouldn't do it for me. But the thing is that I don't think you can let the smokers go out, and hopefully you'll get them to come back more often for maintenance. To say, look, if I'm going to do your implants, I want you to come back every 3-4 months. We're going to clean these up. We're going to make sure everything's fine, and make sure your pero's under control first, and then place your implants and then get going. Some people lose teeth because they couldn't get to the dentist. They got decay. They didn't lose them because of periodontal disease. They lost them because the decay was too far down, and placing implants is the much more conservative restoration than doing a bridge sometimes.
Okay, I'm going to ask you the same line of thinking, but a different problem. I mean, you and I know, we're both in Phoenix, that Apache Junction is meth. And my homies in California, they can't explain why, but meth is a 10 times larger problem in Bakersfield than it is in San Fran. I mean, I got very good friends, and 2 of them are classmates.
Right.
They're in Bakersfield for 10 years and almost didn't even do a denture every 3 months.
Oh my God!
And now they're doing a denture a day.
Oh wow!
Because so why a community starts doing drug? I mean, it's multifactorial.
Sure, absolutely.
And we know in our valley that Apache Junction, if you ask any police officer, in Maricopa, they say, yeah, if I go to any trailer park in Apache Junction, I'll find 3 meth labs.
Exactly.
So they come into your office and they're losing their teeth from meth, and they flat out tell you, I'm losing my teeth. They grind them, they crack them. So what do you does that change your treatment plan if I lost my teeth from meth?
I think you have to look at the case on a case and see where they are. If they're still doing meth, I'm not going to work on you till you're clean, first of all. But and I've done some cases with some other GPs on some meth cases, and they said, okay, well, we need to take these teeth out. We need to do some crown lengthening here because some teeth can be saved, because if you look at the costs, placing an implant is much more more expensive overall than maybe trying to save a tooth. And it's easier to try to keep a tooth sometimes than it is to try to do an implant, save an implant. So you have to look at a case-by-case basis. But in these cases, if you have a patient who's got decay, rampant decay, maybe not every teeth aren't for everybody sometimes. So you say, you know what? You try to treat and plan them out so that you can do implants with an implant-supported denture, which they won't have to worry about decay. But if you can get them coming in every 3-4 months to maintain them, that might be the best. But at least if they go back on that, they're not going to lose their teeth to decay. They're not going to lose their implants to decay, but probably to gum disease.
Well, so, I mean, I'll be straight up front honest with you, Alan. In my career as a dentist and 28 years in Ahwatukee, my highest failure rate is with meth patients.
Yeah.
I don't care if they're from Maricopa, they're from Apache Junction. It seems like you can do 12 fillings.
Yep.
And in 6 months, those 12 fillings all need 12 root canal buildups and crowns.
Yep.
And in the few that I was dumb enough to keep going and did the 10, 12 root canal buildups and crowns, and then 6 months, a year later, that was all mush. I mean, it seems like when you shut off your saliva from a stimulant so strong, and there's no saliva, it's game over for restorative dentistry.
Absolutely. I agree, because they just
but what if they're on meth, game over, restorative dentistry? So I pull the tooth and I just place an implant. What would happen there?
See, in that particular case, I don't know what would happen depending on the case, but I would probably those types of cases you have to look at from not a tooth by tooth restoration. You have to look at from a full mouth restoration. Say, where are we going with this case? And maybe the best option for you right now
is removable,
total edentulation. Get you some dentures, and after things heal and see how the tissue looks, then we can start looking at implants.
I agree with that. We agree on this. If there's smokers, I think being purists that I want to do on smoke, that's not realistic. Humans need help, and
that's right.
And successful people fall down several times. I like the Steve Jobs movie, because the Steve Jobs movie was a classic example of how really flawed people can do great things.
And that's right.
And, I say this, I really shouldn't say this podcast, but like even Charles Manson, when you watch him on an interview, he's kind of a sweet, adorable guy.
Yeah.
But he's a monster.
That's right.
So I mean,
people got his own problems.
People are complex.
Right.
And you just can't shut your door because they smoke, because 1/4 of adults, or 18%, are smokers. That's
right.
That's 1 in 5. But I would have to say that meth use is a redliner. The best thing you can do is just extract tooth, go flippers, go partials.
That's right.
Go removables. But until they stop the meth, until they regain saliva flow, circulation, serous fluid, mucus, nothing's going to work.
Exactly.
in my deal.
They have to realize that they're the major part of the problem, and they have to make a change.
So I'm going to go back to the very beginning question.
Okay.
So I'm listening to you. It sounds good. I mean, if I do a 5-year lease, it's $1,800 a month. I don't care about the balance sheet number of $113,000. I'm looking at the $1,800 a month. And if I upgrade one patient that needs 4 quadrants replay and curettage to 4 quadrants at $800, and I do it myself, so I'm not having the hygienist do it. It's just all mine. How long would it take me to do those 4 quadrants?
It depends. Usually we recommend 2 hours for 2 quads. So at the beginning, when you start off, it takes time to get to kind of get an understanding of how things work out. So we usually recommend 2 quads in 2 hours, and so you take your time with it. You don't have to rush through it. And then a week later, you come back, you check the one side, then you do the other 2 quads the following week. And that's it. Then you're done your 4 quads, and you have patient come back a couple weeks later for a check, and then follow your post-op instructions and everything else. Then get them into their maintenance 3 months after you started the work. So, but after a certain amount of time, it took me a while before I realized I could do a full mouth in about 2.5 hours. So if I do a full,
why don't you do an online course on that where you show how you do a full mouth in 2.5 hours? Because here's one thing I'll throw LANAP under a bridge for, and then I'll just throw Bob Gregg. I don't want to throw his wife, Dawn Gregg, in there because she's the most adorable person in all of dentistry. I love her to death. But a lot of people are cynical that say, well, you know what I don't like about LANAP is I got to buy the $113,000 laser before I get the training.
Right.
Give me some of that training up front. So I've always thought a better business decision for them would be to put some of that curriculum online beforehand, because 113, it's a big number.
Right.
And I think if they saw part of the deal, I mean, it's kind of like you got to give me 113 grand before I show you what's behind door number one.
Well, I mean, let them.
Well, I would let them peek more.
Yeah. Well, we have preview sessions that we bring the doctors that doctors can go to.
And where are those at?
Depends on the rep. I know Terry in Phoenix. We're having
Terry Sundquist.
Terry Sundquist in Phoenix. We're doing one
Shout out
in
to
June.
Terry. Where we're at?
I don't know yet. I know we're doing one in June though.
But is it in Phoenix?
That's going to be in Phoenix.
Well, you know what? I put on courses. This is our 14th annual county meeting, but the staff really doesn't have anything to do between the meetings. So, the Indian Reservation, right by us, we've been putting on smaller events.
Oh, okay.
That might be something you might want to do.
You can always call Terry and she'll arrange it or whatever. But yeah, so we do that preview sessions. But what really got me was the fact that I didn't get the laser until I got the training. Because a lot of companies will just say, like, if you'll go to a meeting and say, okay, well, I really like the laser. Okay, here's the laser. Give me your check. Here's the laser. Here's the thing. We'll deliver the laser. Then we'll send out somebody to go train you. With Millennium, though, the training is, you talk to anybody who's gotten trained through Millennium, it's second to none. So when you come in, the first...
And the training's in Denver or LA? It's
actually there's 3 different places. One is Cerritos near Anaheim. The other was in Denver, and that's during the winter months. In the summer months, they go out to Buffalo.
New York.
Buffalo, New York. So we're trying to have like an
and
East
why
Coast.
Buffalo? Is that tied with the university or
no,
Ivoclar over in Amherst?
It's just a nice area to go to.
Huh.
So
because that's where Ivoclar is headquartered.
But the thing though is that they wanted something on the East Coast. Because a lot of doctors didn't want to travel all the way to the West Coast. So in the summer times, they have it there. Winter we have it in Denver, which is actually beautiful during the wintertime.
I would never go to Denver, not after what the Broncos did to my Arizona Cardinals.
That's true.
I just can't.
That's right.
I can't forgive them.
But Peyton Manning, he was class act.
So I'm sitting on the fence at 113.
Yep.
What more? If I wanted to learn more about this, where would I go?
You can go to lanap.com. There's webinars.
Lanap.com.
Lanap.com. That's the website.
And there's webinars on there.
I personally have 2 webinars on
how
there.
How much are those webinars to watch?
How much?
Yeah.
0.
So my homies went to lanap.com.
Yep.
And LANAP stands for Laser
Assisted New Attachment Protocol, but it's
.com, lanap.com.
lanap.com, LANAP.
There's 2 webinars on there from
just
Alan,
for me, and then there's one from
for free.
For free. There's one from Chuck Braga. There's a couple from
Chuck who?
Chuck Braga, Charles Braga, he was a periodontist in Harvard, and but I don't hold that against him. And then there's also I know Bob Gregg has one. I think there's also testimonials from all sorts of doctors from all over the country. There's other online stuff. There's tons of information.
And then what other periodontists in the valley? Did Ralph Wilson go LANAP?
Ralph Wilson eventually did go LANAP.
Yeah, he's got 5,000 posts on Dental Town.
Yeah. It's one of his all the time in the world to do that. So
yeah, and what other periodontists in the valley?
Well, now there's Ann Blue has one. Ed Mazer, Roy Zajaji has it,
which I think speaks volumes for, because in the very beginning, I
trained most of them. That's the funny thing.
Yeah, because in the beginning it was a few renegade general dentists.
That's right.
And now I feel like
Bruce Nelson.
Now I feel like LANAP started out as a renegade thing, and now it's gone mainstream.
Oh yeah, absolutely. I mean, I remember all these guys made fun of me at one of the Arizona Perio meetings because oh, you're doing LANAP. Oh yeah, this and that. They're giving me all this hard time, and then they just kind of got on board. Like I said, 4 or 5 years later, they said, oh well, you know what? I'm going to start doing this because my friends are doing it. And I want to start doing it too. So, because again, peer to peer. So, anyway, but like I said, 100, 108, 113. It's a big nut to look at. That's a big number. When you break it down, it's pretty manageable. But like I said, if there are dentists out there who want to, especially GPs, I think GPs should be in this much. I mean, periodontists should be in this a lot. But GPs have they can really bring this home for their patients because they can carry the case all the way through from diagnosis all the way to final restorations. Whereas I can only get this little piece of it, then I have to send the patient back for the restoration. So the general dentist can bring this all the way through. So they might not do the crowns for a year while the patient's healing, but they're going to get those crowns or the bridges or whatever, the implants, in the second year, where they can really develop the patient's occlusion and everything else and have a really nice result over the patients.
I want to ask you another thing. Us older guys, and it seems like young kids are very binomial. Everything is yes, right, left, right, up, down, forward, back. And there's a lot of young extremists just like no bridges, it's just all implants.
Yeah, I don't think you can do that.
And I think that doing this 30 years, there's still a place for a 3-unit bridge.
Absolutely. I just did a 3-unit bridge with my mom 2 weeks ago.
Yeah.
She came down to see me to visit me, and she needed a bridge, and I said, okay, I'll do it for you. I went ahead, cut the bridge, and she had a beautiful site for an implant, but she lives in Canada, and I said, you know what, I don't want her to have to come back and see me for this and that. I just did a beautiful 3-unit bridge for her.
I got some friends that are ENTs and some that are rhinologists, and they're looking at some of these disasters and like so the dentist, this all started because the dentist wouldn't file down a second premolar in a molar.
Yeah.
Because that would just not be pure. But he had
Right.
no problem drilling a hole into the sinus, packing it with dead human bone, dead cow
That's
bone,
right.
sticking all
It's
this
sorta
shit
funny,
in
isn't
there, and now the sinus is all messed up, and we got a sinus infection and a yeast infection, and we got and it all started because a dentist wouldn't file down enamel because he
Right.
doesn't believe in that.
Right. Well,
but he'd stick a grenade in a sinus.
It'll
and then
grow
he hit,
bone too, by the way.
And they'll hit an inferior alveolar nerve and have a.
But again, that comes
deal.
down to training and comes down to following
So last
protocols.
question. Last
Yeah.
question.
All right.
Last question.
All right.
There are dentists who have placed thousands of implants who have never done a surgical guide once in their life.
Yep.
And they look at people doing surgical guides saying, what do you need? What are you on, training wheels?
Right.
Dude, take the training wheels off and learn to be a real doctor.
Mm-hmm.
Then there are other surgeons like yourself or Jay Resnick that always use surgical guides. I mean, I look at Dental Town. I don't think you could get 2 dentists to agree that today is Thursday. What's your view on surgical guides?
I think surgical guides have their places. I mean, there are times where I will freehand because it's an immediate implant. I know where it's going. It's like a slam dunk. But again, that comes with experience. But there are times where you want to use a surgical guide to make sure everything's lined up, because you have to remember that implants are a restorative procedure with a surgical component. So everything that I do, especially when I'm planning for my doctors, everything is planned from the crown down, not from the implant up. And so
would you say implants are a restorative? What'd you say?
Implants are a restorative procedure with a surgical component.
That's nice. That's
what it all comes down to. No one will ever see my implants unless we get peri-implantitis and everything goes away, but they'll always see the dentist work. So my job is to make sure that all you have to do is take an impression in the central lab and just screw in a abutment crown and you're done. That's my job, to make sure it's as easy as possible for my restoring dentist so they don't think about it. So so it comes down to training again. It comes down to everything. Do I do freehand implants? Yes. But I've also got years of experience behind me doing guided surgery and everything else. But the majority of my cases, I would say 95 to 90% of my cases, I will not do without a CAT scan, because I will not I want to know.
A CAT scan meaning a CBCT.
A CBCT scan, right. Because I want to make sure that I want to know where that inferior alveolar border is. I want to know the width of that bone. I want to know if I have to do a bone graft before or during the procedure. Because the last thing you want to do, and this happened actually when I was teaching a residency, is I walked in on a surgery that a resident was doing, and the patient was out, they're IV sedated, they flapped it open, an anterior in, they looked at it, oh, there's no bone. So what they do, they just suture it back up, get the patient off IV, patient wakes up, they go, oh, my implant's done. They go, no, we couldn't do the implants, there was no bone. But if they had done the CAT scan, a CBCT scan beforehand, they would have known exactly what needs to be done. Then the patient's making informed decisions. And that's what I look at. They're making informed decisions.
Any brand of CBCTs got you excited, or?
I personally like the Sirona.
The Galeos.
Galeos. I think right now, it's, as far as I can see, right, when I was looking at CBCT scans, it was the easiest software to work with. Like I could just figure out everything else.
And do you think you need one, or just need access to one?
I think you need access to one. A lot of patients, we have doctors coming in our office, like perios and general dentists coming into the booth, and they'll say, well, I'm looking at a CBCT scan this year. We said, look, CBT, it's nice to have it. If you have it, that's fantastic. But it's a break even at best, because a lot of patients are going to pay you $200, $300, $400 for a CAT scan. So you're either going to do it because the idea is, well, I'll have the scanner and I'll be able to do more implants. The problem is that the scanner becomes just a break even point, or you're going to give it away because you want to get the information so you can get the implant in. We tell them, look, if you tap into LANAP first, you'll make enough money, you'll be able to pay for your CBT, you'll be able to pay for your CAT scan machine. Because one, you're going to tap into something that you're not getting, you're getting no money out of, And then you'll be able to do the implants, but you also get the information that you'll get from the CBCT scan. And a lot of doctors who've gone that way, they go, yeah, this paid for my fun stuff. The LANAP paid for my fun stuff, but they found their CBCT scan didn't pay for much. It's a great tool to have, but if you don't have, but you need to have access to one. And around the valley, there's a lot of different. There's 2 or 3 that.
Well, is this a fair? So say my second to last question.
Okay.
So when you buy I mean, how many phones have we had?
I've got 4 or 5
and
iPhones at home.
every 3 or 4 years you wanted an upgrade. I mean, I started with a Motorola flip phone, and then it was this and that. A lot of people are saying, why would you buy a $100,000 CBCT? Because in 5 years, the technology is going to be extinct, and you're going to want the new, latest, greatest.
Right.
Is that a fair?
I think it's mostly the software that's going to change as opposed to the hardware. So I think like the hardware is not going to change at all.
So
I think
just be a software upgrade.
Be a software upgrade. Maybe they'll change a screen, but the overall is probably not going to change that much. The nice thing about, I'm going to come back to Millennium again. The nice thing about the Millennium, there is no upgrades. It is what it is because it's based on biology, so there's no MVP 8 or 9 or 10. It is what it is. The laser that I have that I bought 10 years ago is pretty much the exact same laser that they're selling now. So that's the nice thing about I don't have to worry about upgrading my laser to account for anything, which is nice. So
well, I can't believe that I had to run into you in Las Vegas when we both live in Phoenix.
I know.
Alan, I've been your biggest fan for probably 3 decades.
Before you even knew me, that's even better.
I love all that you've done for dentistry. I love what you've done for so many of my patients. I just love everything about you. Thanks for speaking to Townie.
And I'll send you an email and see what we can work something out.
Let's do lunch in Ahwatukee.
Absolutely. I'd love to do that.
What's your favorite food genre?
You know what? I actually like Zitejas.
Well, that's Ray and 51st.
Yeah.
Well, let's when you get back down.
I'll give you a call.
You got my number.
I got your number. Don't worry about
it. Let's do lunch at Zite House.
All right. Fantastic.
All right, buddy. Thank you so much.
Thanks a lot for having me.
Thanks, Ryan.